Welcome, welcome to the University of California Student and Policy Center. My name is Catherine Baker, and I'm going to move over here so we're on camera a little bit better. Thank you for the hand signal. I'm very happy to welcome you here to UC Student and Policy Center for what I think is going to be a great program today. Raise your hand if you've been to a program here at the UC Student and Policy Center. Okay, terrific. I'm glad to see the repeat offenders. For the newbies, this center is a very real and important way in which the university works to meet its public service mission to the state of California. Of course, UC is known for its fabulous faculty, excellent research and instruction, but they also have a presence in every single county, assembly, senate, and congressional district in the state of California. And they have innovators and researchers and experts, both student and faculty, in every aspect of modern life. And the UC wants to be of service to our policymakers, those who really do the work and advise them, and to help them solve the challenges facing California. So this center is very much a way of doing that. We do it through lots of programs, and today is one of them. So I'm very happy to welcome you here to the center. I want to also let you know that when we have programs, we love to highlight our UC family. And one today, if you haven't heard this acronym before, is one of my favorite to say. CHBRP. The California Health Research Benefit Program. Health Benefits Program. Review. This is why I am not telling you what CHBRP means, but they are our co-host today, and I'd like to welcome their director, Garen. Garen, thank you for being here, and tell us about CHBRP.
Thank you so much. It's great to see you all here today. Again, my name is Garen Corbett. I'm director of the CHBRP program, California Health Benefits Review Program. We could not afford a vowel when the program started, but we're working on it. It's part of our long-term plan. For 22 years, the program has existed to provide a bridge between the policymaking world here in Sacramento and the expertise of the university and bringing and supporting evidence-based policymaking. So I would like to also call out the phenomenal staff, the tens of thousands of staff across the UC system, and unique programs like ours that work with phenomenal faculty and researchers from across the system. And what we do is we, in 60 days or less, provide an unbiased, independent analysis of introduced legislation before the policy committees, typically the health committees, hear the legislation. And that's not just coming up with the cost, but that's looking at the underlying evidence, looking at community and public health impacts, as well as the policy analysis piece of that. So faculty can be really fast too. And I think today's fantastic topic is just sort of one piece of the puzzle with 20% of our economy around healthcare that we consider in analyzing the kinds of legislation that the CHBRP program does. So it's a pleasure to be here today, and welcome, and I will turn it over to our fantastic panel.
Oh, no, I'm taking that.
Oh, okay. Take it. Oh.
Yes. Thank you, Garen. Let's give an applause to CHBRP, please. I want to make sure we show our appreciation. And so just to set the stage a little bit before I introduce you to our panel, has anyone seen how prescription drug costs have steadily gone up in the last few years? I'd like to give you some facts and figures about that. First, the Department of Managed Care in 2023 said that health plans pay about $13.6 billion for prescription drugs just in 2023. That's almost a $1.3 billion or 10% increase from the previous year. Actually, it's almost 11%. It's 10.8% increase from just 1 year. Since 2017, prescription drug costs paid by health plans has increased nearly $5 billion, and that is with a B, or 56%. Now, legislative leaders, as we know, and Californians are really focused on how to make life more affordable in our state. And of course, access to prescription medication is important to healthcare and treatment and good outcomes. And so we want to help the state address this problem, and today's conversation is part of that. We're going to talk about what's driving those costs. I usually don't use talking points, but I'm trying so hard today to do that. What drives those costs and what can be done about it, knowing that we hope you'll leave today with some ideas. So Today, we are very fortunate to have a terrific moderator, Kristin Hwang. She's an award-winning health reporter from CalMatters. She covers healthcare access, abortion and reproductive health, workforce issues, drug costs, and other emerging healthcare matters. Her recent work has been recognized by the Sacramento Press Club and the Asian American Journalism Association. So thank you for being our moderator today, Kristin. Let's welcome Kristin. We also have Dr. Marilyn Stebbins, who's an award-winning pharmacist and professor emeritus of clinical pharmacy at UCSF School of Pharmacy. She focuses on developing innovative practice models for pharmacists with a focus on underserved populations. She has taught several courses on health insurance, on Medicare Part D, innovative practice models, managed care, drug pricing. I've seen a preview of what she has to say, and it's amazing. So we're very happy to have her here. And she's also a peer member with CHBRP. So please thank also Dr. Stebbins. Thank you for being here. And last but not least, the gentleman going last, thank you very much. Dr. Watanabe, Jonathan Watanabe, is a nationally recognized geriatrics pharmacist. He's also a pharmaceutical policy leader and focuses on, I know you're chair of the Department of Clinical Pharmacy, correct, at UCSF, yes. He also works very much on quality metrics for long-term care and transitions of care, which is with our aging population. The silver tsunami is important for us to include in this conversation, and is also a peer faculty member with CHBRP. So with that, we thank Dr. Watanabe, Dr. Stebbins, and Kristin. Take it from here. Thank you.
Thank you so much, Catherine. So when I talk to people about healthcare affordability, the conversation inevitably always lands somewhere along the way on the cost of pharmaceuticals. And as Catherine pointed out, with a sort of year-over-year increase just between 2022 and 2023, nearly an 11% spending increase by health plans on prescription drugs, it shouldn't be a surprise that in recent years, spending growth on prescription drugs has outstripped spending growth on hospitals and other cost drivers since 2022. And our state lawmakers are often trying to get their arms around this issue, but it is a very complex issue. So I'm going to give just a quick summary of what has happened in California recently before I turn it over to these much more illustrious experts to lead the conversation. In recent years, California has stood up the Office of Healthcare Affordability, which has instituted a industry-wide cost growth cap of 3.5% for this year and the next year. And the office is also tasked with analyzing what some of the cost drivers are for various sectors, including the prescription drug spending, and coming up with data, reports, policy recommendations for our lawmakers. In 2020, former Senator Dr. Richard Pan also authored legislation that put California on a path towards manufacturing its own high-cost, high-use drugs. And the first drug that California has attempted to do that with is biosimilar insulins. Governor Newsom announced that the state's first biosimilar insulin would be available in 2024. I think that was a little bit too enthusiastic of a timeline. I've reported that endeavor is likely at least a couple of years behind schedule. We are already in 2025. And there have also been other legislative attempts like instituting out-of-pocket cost caps for various prescription drugs, as well as requiring healthcare coverage, health plans to cover very expensive drugs like the Ozempics of the world. But the story of how we got here is very complicated. So Dr. Stebbins, I will give it to you. Can you give us a primer on how we ended up in this high-cost landscape?
Are these on? Okay. I tend to talk really loudly, so I'm going to try to talk more softly. I think all of you know these are great introductions. We are very different from the rest of the world when it comes to our drug spend. And I think we have to come backwards and look and try to figure out why is it that our drug spend is so much higher than the rest of the world. And I think you've got to start with the monopolies that we have here in the US, that first and most importantly, drugs are patented. So pharmaceutical manufacturers apply for a patent that lasts typically 20 years. That patent time also includes the development and the testing and the marketing of that drug. So the typical drug is on the market with an exclusive patent for about 7 to 10 years. And that means no one else can touch it. So when that price is set, there's no competition in the market. So therefore, the price remains what the market will bear. On top of that, the FDA is allowed to grant exclusivities to these drugs and to the manufacturers of these drugs when something new happens, like they've created a new indication for that drug, or they are now, they've tested it in children and they have a new indication for use in children. You get these exclusivity extensions that can further the patent, or basically further the exclusivity. So what is it that actually helps drive the cost of drugs down? It's when that patent and exclusivity end. And when the patent and exclusivity ends, we see the generic manufacturers enter the market. Now, if you only have one generic manufacturer entering the market, we don't typically see they actually get an exclusivity for a certain amount of time for their generic. So we don't see the price of the brand or the generic drop much. It's when you see 2 generic manufacturers enter the market or more. So you'd think, okay, we get rid of these patents end, and then we get to have this competition. Well, the system is gamed oftentimes, because what then happens is the manufacturers enter into pay-for-delay agreements with some of the generic manufacturers, where they pay them more than they would make on their generic drug not to enter the market. So again, we see this price of drugs remain artificially high because we don't have competition. The other thing we see is mergers. So we see big pharmaceutical companies merging with other companies that may have their competitor, or it may have the generic they may buy a generic manufacturer that has the generic for their branded drug. That muddies the water again and keeps the prices artificially high because they've then lost another competitor. So those are some of the things that are driving our prices. But we also see that sometimes when one of the things that's sort of a counterweight to these high prices is when payers can actually get negotiating power. So a payer or their pharmaceutical benefit manager, their PBM, can go and if they bring more business to the manufacturer, they have more negotiating power to drive the price of that drug down for the payer. Well, it's for the payer, but because of lack of transparency, the patient doesn't always see that price lower, but the payer does. So the payer may be actually getting some good deals. Well, if you think of some of our large government payers, we're going to exclude the VA, who can negotiate drug prices, but if you think of payers like Medicaid, unfortunately, they don't have this sort of negotiating power, and they don't have it because they are forced through agreements that they have to cover almost every drug. If you cover almost every drug, you don't have negotiating power with a manufacturer because you're not giving them any preference to help them drive their price down. So all of these factors are really pretty tough on the market, keeping prices higher. And we don't see this in other countries because they negotiate their own drug prices. So you have one entity negotiating drug prices. I think we have to also understand that another contributing factor to drug spending is prescribers. Prescribers making choices about drugs and choosing a drug when there is a comparable alternative that is more cost-effective. So again, intentional or not, prescribers drive up the price of drugs too by using more expensive agents. The other thing you'll hear on the market is we need these prices. Pharmaceutical manufacturers have to set these prices high because they spend so much on research and development of these drugs. Well, I'm here to tell you that unfortunately there's no data to support that. That actually, in fact, they spend so much on research and development, and that the difference between research and development and the cost of their drugs, there is not a good correlation with that. So that is a bit of a misnomer. So I think...
And it is known they spend more on marketing
than they do in
That
R&D.
is-
So marketing to those prescribers that are making those choices. So I think what you have to take away is that higher drug costs in the U.S. are really a result of granting government monopolies to drug manufacturers, combined with coverage requirements for government-funded drug benefits like Medicaid. And with that happy news, I'm going to turn it over to my colleague, Dr. Watanabe.
Did you? Yeah.
Oh, no, take it away.
Oh. Yes, I mean, the great points, and again, many thanks to UC and California Health Benefits Review Program and all the people that helped make this possible, so really appreciate the opportunity. Yeah, so I mean, like, some of these things are just an interesting cross-section of reality that we've never really run into. So Marilyn made so many interesting points that are useful for the dialogue, but some things you just have to understand is that we are an aging population, just like the rest of the developed world and even some of the developing world. So the number we used to say was every day there's 10,000 baby boomers that turn 65 and then basically enter into Medicare. I think they say now it's closer to 12,000. But even at 10,000, that basically means in this hour we're going to spend together, that's well over 350 people in the United States that are turning 65 and that are entering into Medicare. So there's just a rapidly aging population that goes into these arenas that are high utilizers of medications. So your average senior has 2 or more disease states. They're on at least 2 or 3 medications, so they have multiple morbidities, and they're on multiple medications. That in itself is going to drive up utilization. On the other element is we actually have fewer people paying into Medicare than we historically have. In the 1950s, there was 16 workers paying in for every Social Security recipient. So basically people that are going to be extracting versus what's going in. That in 2010, that's about 3, right? So we just have fewer people paying into something and more people now withdrawing. And that's why if you just look at the actuarial numbers, Social Security would go bankrupt in 2030 and Medicare would go bankrupt in 2034. It's not, because Congress can always put more money in there if they do. But that's how they can kind of sustain these things. But it just gives you a real-world flavor for the challenge of when you have an aging population and we have more increasing medications. Our drug bill in the United States is about $500 billion with a B, which is larger than some economies. We spend $4 trillion is spent on just the U.S. medical bill, which is larger than Germany's entire economy. Germany is the 3rd largest economy in the world. So the complexity that Dr. Stebbins talked about is exactly right. It's monolithically large. It's incredibly complex. I was a part of this effort that began in 2016 called the Making Medicines Affordable Consensus Study Report, right before the first Trump administration, actually. And they actually had the CEO of Lockheed Martin lead that consensus study. So there was pharmacists, physicians, policy experts. There was former senators from New Mexico. Can't remember his name, but he was amazing. But they literally got a rocket scientist to try to figure out our healthcare system, because that is literally the complexity of it, right? And so, as Dr. Stebbins said again, the number of people that are involved. I used to do this exercise. We don't have time, but where basically following the money. There's providers, there's health systems, there's payers, there's PBMs, there's wholesalers, and remember, all of these middlemen, and there are many, they were there as a solution at one point. The PBMs that are kind of getting their turn right now in the media, they were with pharma, Merck Medco, some of the original in the 90s. They were an artifact. They were of pharma trying to improve the system. So these are just some of the realities that we face. Then on top of that, we do have improvements in medications. There are things that we can treat that we couldn't before, but those have an inordinately high price. I think we have to get better at really delineating how value can be assessed, as Dr. Stebbins again alluded to, getting better at some of these efforts that get deployed, for all intents and purposes, better in other places outside of the US where they actually do look at this information, right? Norway, they pay almost double what we do for a gallon of gas. They pay 150% what we pay for a Big Mac, but they pay about half what we do for medications because they have the ability to negotiate. Just like you like the ability to negotiate when you go buy a car or all these other things. You can know what the price is, you can look at what the contents of value, and you get to negotiate about that. Currently, Medicare has only been able to do that for a year, and it was only on 10 meds. And now we're going to be able to do that on 15 more next year. But this is the first time where this has ever been done. There's commercial plans that do have the ability to negotiate, but for Medicare, which is kind of remember, Medicare and Medicaid, that's the largest payer in the world. So a good thing to know if you want to know, like, in terms of national payers, I think this is always really important for folks that are just like, oh, we don't want national payers, we don't want socialized medicine. The Center for Medicare and Medicaid Services, which each of you is going to be entitled to at age 65, that is a federal national payer system, and it's the largest in the world, right? So we already do have this. It just happens to be you have to be 65 or have a disability and pay in to get it. But I think these are sort of those important dialogues, and now we have that component where we can start these negotiations have now begun to ensue. And now if we're going to talk about the negotiation, but yeah.
I am curious. You bring up the Medicare negotiations. Do you expect that ever to have an impact on the wider prices for the commercial market?
Yeah, I think that's the idea, is that basically where Medicare goes, including how we do so many of our payments, that's usually the same system that gets applied for many others. So that's the notion. They actually do, but they do negotiate in the commercial space, but to the extent
it's just a black box, right?
Yeah, by law, it's a black box. So the FTC actually protects rebates as basically there was a case where Pfizer, I think. There was legislation in Texas because the Texas legislature was actually given the rebates that the Medicaid program were, and those are technically protected. So this game, the notion is, which I always hear the analogy is when you're playing poker, you can't see everybody's cards. So allegedly, the rationale for the negotiation of why these things are secretive is to make sure that they can bring down prices. The problem has been alluded to by all the speakers before me is prices keep going up. But yeah, that's the notion, and that hopefully it will begin to leak in as Medicare is such a large payer that having this negotiation ability will start to lead to something that's more meaningful. And I think if you look at the projected savings, they are real savings. But whether to see it take on its full impact, like what, as Marilyn mentioned, what we see in other countries, I think that still needs to be seen.
Mm-hmm. Well, you've both outlined, really fundamental root causes for the reasons why prices are so high. And if you've never Googled to try and look up a chart, because different organizations have made charts of all the different players in the pipeline, I recommend you do, because it's mind-boggling. The arrows go in all kinds of crazy directions. What sorts of policy levers can be pulled to try and address some of those root causes of high prices in the U.S.?
I think, again, we have monopolies for brand name drugs because of patents. So I think that's not just policy, that's law. So patent law needs to be looked at again when it comes to drugs, and looking to say what is reasonable and what is a reasonable patent. I think also from a policy standpoint, we need to really dig into these tactics to extend the patent and exclusivity of, these pay for delay or mergers, and figure out how we avoid doing those or allow them without allowing it to impact the generic market coming to fruition for those drugs.
Yeah, I mean, the generic and biosimilar portion is really a really important piece of the puzzle. I think that we have a paper that hopefully will be out soon, where we looked at do these biosims, so particularly within the insulin space, so do these biosimilars make a difference? And we see that, and again, this is just like a little bit about just a little bit about instruction on how these things work. So there's generic drugs. So when you think about, when you go to the pharmacy and there's brand Tylenol, and then right next to that there's something, the pharmacy brand acetaminophen. All right, Tylenol is the brand, the acetaminophen is the generic, right? So they both, and they're FDA approved to be, you have to submit this testing to demonstrate that they are therapeutically equivalent. They're called AB rated. That's for those pills you can swallow. We call those small molecules. Those for the generics. Then there's this other space that's recommended by used to be CBER. There's a whole bunch of abbreviations, which I know I was told not to do. But there's two different agencies at FDA that regulate biologics. Now some of that is getting spun over to the drug group. But they're the ones that look at these biosimilars. Why are these biosimilars treated so differently? Because these are these biologics, like when you think about insulin, these things are, they're grown. So you clone this into a living cell, and then that produces this, and then you lyse it, and you take that. If you think about insulin, that was kind of the original biologic. That is sort of the notion why it's more complex for these generics that are biologic, and we're calling those biosimilars. For more than 15 years, there's been a lot of interest in trying to get these biosimilars to market because they are inordinately expensive and they're increasingly used. But the challenge has been, as sort of as Marilyn alludes to, the manufacturers haven't been necessarily incredibly supportive about another biosimilar coming in and taking that market, as we have seen in other countries where they use them more frequently. So trying to make that biosimilar market healthier and better functioning has sort of been a dream in the United States for quite a while, and we're starting to get to some of that. And we see it does make a difference. But the price drop, here's the last little bit, the price drop from a generic small molecule from the brand to the generic, so for the folks who remember Lipitor, which was the highest selling drug in the world, Lipitor versus atorvastatin, you were eventually, when it got commoditized, you're gonna get 90% off, right? But for the biosimilars, the drop has been much less significant. It's about 30, 40%. But the notion is, now that we have these kind of interchangeable biosimilars, these ones that can be substituted by a pharmacist without having to get a new prescription, you're gonna start to get real savings that the patients can feel. Mm-hmm. That's the hope. And in our analysis, we're seeing that some of that's being achieved. But is it fast enough?
Is that interchangeability the primary reason why there hasn't historically been as much uptake of biosimilars?
I think it's multifactorial, but one of them is we haven't had people making biosimilars. I mean, it's been very difficult to get a biosimilar out there because of the manufacturing technique. There's also manufacturing shortages and all kinds of things that happen with a biosimilar that may be different than a small molecule drug. So it's not the same where when Lipitor went generic and then you get one generic manufacturer and then you get 25 generic manufacturers that drive it down. Biosimilars, it's a much smaller biosimilar market. So I think we're seeing that as a...
What about...
We've had our first interchangeable biosimilar a year and a half ago.
Yeah, I mean, that's it. It's very new.
What about the role of PBMs and biosimilar uptake? I mean, I've read, I'm sure you guys are much more expert on this, but I've read that often the biosimilars or the generics are simply not covered in the formulary.
And I will tell you, because I actually just spoke to a PBM recently about an issue with a biologic. And they actually told their individual clients to go international, because international reimportation for an individual to do it isn't as scrutinized. You can't really do it as a large company, but telling people individually, go get your drug for Crohn's disease from another country like New Zealand or Canada, because we can't get a contract for it. By the PBM doing that and sending people out of the country, suddenly the market came to them and said, we don't want to lose this. So they got basically two folks to come to them and say, okay, now we're willing to play. We will negotiate. So I think it's all a matter, it's really what the market will bear, and the tactics that are used are tactics that are used throughout business, not just drugs.
Yeah, I am often told that there are no heroes in healthcare on the business model side of things.
There are lots
Not
of
at the
heroes.
individual level, but I know, so we're talking to a California audience. I know a lot of the things that you've both brought up are sort of regulated at the federal level. Is there anything, or where is the place of state lawmakers like our California legislature in trying to sort of meet this affordability crisis?
I think there are certainly attempts, and I know that's why we're here. Is so much of what CHBRP has done is trying to evaluate to find out. I think there's been many kind of in terms of the motivation for a lot of the bills that have been produced is try to increase patient access, trying to increase patient affordability, but when you reduce, I think the thing that you have to always consider about this is even when you reduce the out-of-pocket spend, the price doesn't go away. It gets shifted, and so oftentimes when we look at things where we improve the out-of-pocket cost, that actually basically means that that money still needs to come somewhere for the manufacturer to be paid, and so where that lands up, if that lands up in coverage, if that lands up in premiums, if that lands up in deductibles, like this one of these things is, I can kind of move it, to another side of the room. It didn't go away, and so I think those are some of the challenges if we don't get to some of the root causes of figuring out how to make it more affordable, how to reduce some of these. It's as I say, we're in healthcare. These are sort of Band-Aids. We're kind of addressing the symptoms. We're not addressing the cause. And I think that those are some of the components. And again, we're back to the biosims or back to negotiation. Yeah. Is if there were places where if you had really meaningful material reduction in costs, and then that's coupled with negotiation or some of the deals that these payers will make, I think then you can see some ways that patients will really feel these improvements. But I think that, as we said in our prep call, as things are moving they're getting so expensive so quickly that you've got to have really substantive changes that are going to make it beneficial for most that are really experiencing it. I think those are some of the aspects that we really have to get at. It's whatever the economist that just passed away. It's the price, stupid. Some of these things we need to figure out how to really make that, how to change that, not just erode it, but to really lower it. And I think we're still a ways from doing that.
Do you have anything to add, Dr. Stebbins?
I think it's some of the efforts in California to perhaps produce our own drugs that have, and as you've stated, haven't quite gotten off the ground, are good starts. So I think that understanding that it happens at a manufacturer level is an important place to start.
Yeah, I think that I think I had more than 100 health systems. It was a program that began in Utah through but it was called Civica RX was the group. But basically their goal was to make 100 essential of the often used generic medications that are supposed to be inexpensive to keep it inexpensive. But they deliberately actually kept that list confidential before they released to make sure that the other manufacturers wouldn't just kind of swoop in and then just try to beat their price, basically invalidate the effort. So I think these are important steps, but it sure would be, I think ideally you just have a healthy market. I think that's what we just have to start to develop.
Like a market with more competition. Okay. Well, I think we're about at the time for audience questions. Catherine, I don't